Okay. Okay. Welcome everyone. Good morning, good afternoon, and good evening, because we have folks from all parts of the world today. I'm Viral Jain. I'll be a host for today's Journal Club, and it's my really good pleasure to invite Dr. Saina Jewel and Dr. Gunn to this session for us. So a brief introduction. Many of you know Dr. Jewel. She's the Division Chief of Neonatology at Seattle Children's Hospital and University of Washington. She did a PhD in developmental biology at University of Chicago, and she leads a translational neonatal neuroscience research program with a focus to identify new therapeutic approaches to neonatal brain injury. She also has been the chair of neonatal subboard of American Board of Pediatrics, where she writes our board questions, which all our trainees appreciate. She's also the member of the Committee of Fetus and Newborn, and is the past chair of the Developmental Brain Disorders of NIH. And she, as testament to her educational commitment, she's also the co-editor of Every's Disease of the Newborn. Welcome, Dr. Jewel. And next is Dr. Gunn. He's a professor of medical and clinical physiology and honorary professor at Faculty of Medical and Health Science Pediatrics, Child and Youth Health at Auckland in New Zealand. He obtained his MB-CHP in medicine and PhD in pediatrics at University of Auckland, New Zealand. He's also the fellow of the Royal Australasian College of Physicians. His research interests is in mechanism, detection, and treatment of perinatal and prenatal brain injury for it. And we have one of the two of the most prominent people working on brain injury in today's sessions for him. He's also a prolific researcher, and he's been awarded numerous medals for defining research work, such as the Research Excellence Medal, the Bevan Medal, and the Triennial Medal. Welcome, Dr. Gunn, all the way from Australia. And last but not the least is David McHugh. He's our trainee presenter all the way from Australia and Monash University. And I hope he brought his Aussie humor along with today. David, the stage is all set for you.
Great. Well, first of all, thanks very much for the opportunity to present today, and thanks for the support from Dr. Jewel, Dr. Gunn, and Dr. Jain for the making of the presentation today. So today we will be discussing the HEAL trial, or trial of erythropoietin in hypoxic ischemic encephalopathy. Firstly, as I am presenting from Australia today, it is customary to make an acknowledgement of country, and I wish to acknowledge the people of the Kulin nations of whose land we're gathered here today. I pay my respect to elders past, present, and future. And I have no conflicts of interest. So, as we are all well aware,
David, your slides are not changing on screen.
Okay.
Try sharing again.
No, it changed on my screen.
It changed? Okay.
Yeah.
So we have the graph now of the cases globally. Yeah.
Yes.
Okay.
Yeah, great.
Go ahead, David.
Great.
Yeah.
So as we are well aware that HIE, or hypoxic ischemic insult or encephalopathy, has a great mortality and morbidity globally, and this in low and middle income countries make up greater than 85 cases percent of the cases globally, and they also have more severe end of the spectrum in terms of encephalopathy in these countries. Our current modality or best treatment that we have to use at the moment in a high resource setting is hypothermia. However, it's not the silver bullet, as 20% of infants who receive hypothermia will develop CP, and the longer term outcomes at school age, they do worse in comparison to their peers with lower cognitive scores, and they score lower in both motor and behavioral scores in comparison to their school-age peers, and ultimately require more support when they head to school. And in low and middle income countries, as I said before, that they have higher numbers of hypoxic or HIE, and they also have worse, more severe HIE. This may be because they have their other comorbidities, and the infants may not be as well during the pregnancy. The infant or the neonate may be growth restricted, they have lower birth weight, and the type of hypoxic insult may be different to what we see with sort of the subacute or evolving hypoxia over time. More neonates are born outborn, and there is less interventions like the emergency cesarean sections. Unfortunately, the recent Helix trial showed that there was higher mortality in these lower and middle income countries with cooling. So it begs the question, is there any other therapies that potentially may help this group also? So to quickly run through the pathophysiology, so when there is hypoxic insult, there's reduced cerebral blood flow, reduced oxygen delivery, which leads to reduced ATP production, and the brain goes into an anaerobic stage. This then enters a cascade of where the cells release lactate, glutamate, they become quite exotoxic, and there is a surrounding free radicals, which causes oxidative stress and leads to cell death. There is a release of other factors which cause inflammation, and that's what we see in the leading to necrosis after. So a recent study, a review study, showed that our current management for in the NICU to help with HIE. So firstly, I think it's important to mention that it is really important to have a neuroprotective bundle. So preventing any changes, any severe changes in carbon dioxide, glucose, and blood pressure. And a recent published study just this week showed the importance of maintaining normal glycemia, and this preventing long-term neurodevelopmental outcomes, or neurodevelopmental outcomes. As we discussed prior, therapeutic hypothermia is our mainstay of treatment in the early phase. To prevent this exotoxicity and oxidative stress, but we're now looking to other therapies like erythropoietin, melatonin, or stem cell therapies. So that brings us nicely then to erythropoietin and its mechanism of action. Erythropoietin can help reduce inflammation, and it reduces tumor necrosis factors, and which ultimately lead to apoptosis and cell death. It can help scavenge these oxidative free radicals like nitric oxide, which cause oxidative injury, and then reduces glutamate toxicity, which leads to that cascade of exotoxicity, and leads to cell death. It may also help stabilize the brain barrier, and it can help build brain in the long term with neuroregenerative practice. Comparing this then to the mechanism of action of cooling, it actually has quite similar mechanisms of action. So it similarly reduces glutamate and reduces this exotoxicity. It also scavenges and reduces the generation of oxygen and nitrogen, or these reactive species. It reduces this cascade that leads to apoptosis, and also reduces the inflammatory mechanisms. So there is sort of some overlap between erythropoietin and cooling. So background studies in animal models showed that erythropoietin had quite good effect in terms that it could, in rat models, in this review article, it showed that it reduced the size of an infarction in a stroke. This other review study showed that between doses of 1,000 to 5,000 units per kilo, it showed both functional and histological improvement in rat stroke. And looking at the sort of timing of the EPO then, in this rodent stroke model, EPO EPO was given days 7, 10, and 13 after the injury, and it improved more physiological and behavioral outcomes in this group. In other groups then, in piglet group, this group had hypothermia 1 to 13 hours after an injury, and received EPO on hours 1, 24, and 48, and showed an improvement in EEG, and also showed this neuroregenerative properties. In primates, similarly, it was given on days 1, 2, 3, and 7. However, it didn't, when combined with hypothermia, it wasn't statistically significant. And then with Dr. Gunn's group in Auckland, in the sheep group, they gave high dose infusion of EPO 3 to 72 hours after the insult, with hypothermia coinciding. And it was felt that there was, or it was shown that there was little additive effect when combined with hypothermia, potentially due to these overlapping mechanisms of action of cooling and EPO. And these are just two previous studies on EPO. Yeah.
So I think it's a good idea to revisit the background which David has laid for us. So starting with you, Dr. Jules, can you give us some more insight how EPO became the front line, the main thing to look for as adjunct for HIE, why it was the most studied one compared to other options we have?
Well, there was a lot of background support for EPO neuroprotection. Having said that, now in retrospect, I think we can say most of that data was in rats and mice. That doesn't necessarily translate very well to humans. Most of it was done in animal models where EPO alone was used. So at the point in time when we were planning the HEAL trial, there hadn't been much work done using both hypothermia and EPO together. Mm-hmm. So I think it was really the front runner at that point in time. There was ongoing work with noble gases as well, pretty much at that same time. And then I think Nikki Robertson has been working on melatonin for years, but that hadn't quite come to the point where it was ready for phase 3 trials. So EPO, I think, was definitely at that point the front runner.
Dr. Gunn, you have anything to add to that?
Yes, I mean, the thing that is most striking to me is the lack of evidence that the combination of EPO plus hypothermia is protective. So the issue isn't that erythropoietin isn't uroprotective. I think even in the sheep, we found significant protection with EPO alone, certainly as late as 3 hours. Although the window opportunity seems to be less than for hypothermia. What was lacking was compelling evidence that there was benefit from the combination. Even in rodents, there were 2 back-to-back papers published in pediatric research a few years ago, again showing very limited effect of the combination. So
I think one showed a positive effect and one showed no effect. And then there was the primate study, and that was about it at that time.
Yep, exactly. And even the study showing benefit showed a borderline benefit. It wasn't a dramatic. This is clearly synergistic. Even it was still less additive, less effective than the individual effects. So I think that's the one weakness of the background evidence was compelling, a lack of compelling evidence. The combination is better. But having said that, again, I agree completely with Sunny. There isn't anything else that's ready for translation. Even now, I don't think there's anything that we can really say. We can really say that there's something that I would be confident in taking to a large phase 3 trial.
Yeah. So I think at that time when Dr. Jules started the study, there was some evidence at that point, and I think Dr. Jules moved forward with the study to give us a more definite evidence whether it will work or not. David, you want to move forward with?
Yeah, cool. Thanks.
I guess maybe I should just stop for a second and say we also had a phase 1 and phase 2 trial that were supportive prior to starting with the phase 3 trial that we're going to discuss today. So we had a randomized controlled study of 50 kids. The 25 who got EPO outcomes were better. You could argue with that and say, well, if you just moved 2 of the kids over, it was no longer significantly beneficial. But at that time, we had a phase 1 trial where we looked at 1-year outcomes that wasn't randomized in control, and a phase 2 trial where the 1-year outcomes were better and MRI findings were better in the kids who received EPO. So that was in addition to the preclinical trials.
Yep.
Go ahead.
With the Wu 2016 paper, it's important to remember that at least 1 child was indeed really should not have been recruited, that they had an additional neurological diagnosis. So I think this is an important question of principle, is that wasn't obvious until the child was a year, 18 months old. And that's typical of additional neurological diagnosis. You don't necessarily diagnose them at birth unless you're willing to do whole body genome sequencing at birth, which I think that's an expensive, even nowadays, it's still an expensive approach. So do you retrospectively say, okay, that child shouldn't be randomized and you take them out? And if you do, then Wu does not show a significant effect. Or do you say, well, that's how we played the cards, that's how they fell. We just have to take it as is, as randomized. I mean, I think that's a difficult question to deal with. I'm not pretending I know what the answer is, because I don't.
Yeah, and that leads us to this journal club to see how we can further use this information to design further trials in the future. David, you want to continue with your presentation?
Yeah, and then also we have discussed the Wu trial, and then in India, a randomized controlled trial of 100 infants of EPO versus placebo in moderate to severe infants. These infants weren't cooled, and they showed significant reduction in cerebral palsy, and this was back in 2017. So then moving on to our trial, the HEAL trial, which was recently published last year. So in terms of the background then, It was a multi-center, double-masked, randomized, placebo-controlled trial. As we said, it was a phase 3 trial that occurred in 23 hospitals across the US, and just over 501 infants were enrolled from 2017 to 2019. And high dose EPO plus cooling versus placebo plus cooling were compared in infants greater than 36 weeks with moderate to severe HIE.
So, Dr. Jewell, it's a massive trial to design, and then data was somewhere in favor, somewhere not in favor. How hard was it for you to convince the centers towards this trial? Any difficulties you face which all the trainees can learn from?
Well, I think, it's complicated to put a trial like this together. And this was just, I had already done the PEANUT trial, which is a trial of erythropoietin neuroprotection in preterm infants. But we didn't have the result of that yet. So the feeling at the time was very positive. You have to have equipoise, but there were units already overseas that were using EPO for neuroprotection, and we're careful to say, please don't do that until the results of the phase 3 trial are in. But I think that the general feeling was that the preponderance of evidence was in favor of EPO being neuroprotective. And the fact that there was little data about using it together with hypothermia was not appreciated at that time, that was so important. The one trial, small trial, I have to say, that did look at it together was in non-human primates, and that was positive as well, showing benefit. But again, that was a tiny trial due to the expense of the non-human primates. So I think the majority of the evidence that we had at the time was positive. So basically how we got sites, we had criteria for how many babies they had per month, per year with moderate to severe HIE. That was a baseline requirement. And then there were other requirements, like they had to have an investigational pharmacy that was available 24/7. They had to have research coordinators and so forth. It's like all the nitty-gritty details of how do you run a successful trial. So it was great to have the experience from PEANUT already. It was super helpful.
So, Dr. Gunn, so there was equipoise, at least in the US center, about how were the things before this trial was done in overseas, in Australia and New Zealand specifically, about the use of erythropoietin for neuroprotection?
Oh, sorry, what are you asking me?
So before the trial was done, it seems that there was equipoise in the US regarding the use of erythropoietin, and some centers were using erythropoietin. How was the scenario in Australia and New Zealand regarding
it wasn't the erythropoietin by itself or in combination was not currently being used in Australasia.
Okay, good.
So people were in equipoise. They thought it was kind of 50-50, and they absolutely were happy to join in the trial. I mean, I've had this discussion with our colleagues in neonatology several times, and it's fair to say that they're very conservative. They don't want to do. They're not going to take on something that's not evidence-based, but they are more than happy to back good quality trials. And then if they come out positive, then they fight for the resources to implement them.
Yeah,
but they won't do it beforehand.
Yeah,
as a group.
So yeah, a great effort by Dr. Jewell to put this trial together to answer this question for us. David, you want to move ahead?
Yeah, cool. Thanks. There we go. So the aim of the trial was to see if 5 doses of erythropoietin at 1,000 units per kilo reduces the rate of death or neurodevelopmental impairment at 22 months, from 49 to 31%. It's in terms of the neurodevelopmental impairment, it had quite a high goal of a cognitive score of less than 90, which is pretty high on the Bailey tree. So it's 0.67 standard deviations below the mean, or gross motor function, or GMFCS level of 1, so being able to take 10 or more steps. They thought it would show reduced brain injury on MRI and that it was safe. So the inclusion criteria, there were term infants who had perinatal depression, which is similar to what we have in Australia, APGAR of less than 5 at 10, still requiring resuscitation 10 minutes, a cord pH of less than 7, or a base deficit greater than 15 in the cord. I think we just use a figure of 13 here in Australia and New Zealand. The SARNet score had to be greater than 3, so moderate to severe encephalopathy, and cooling had to be already commenced in that 6-hour period. Growth restricted infants were excluded if there was any known genetic congenital abnormality, microencephalopathy, or small head circumference. If the infant was polycythemic, I'm guessing that's because of the mechanism of action of EPO, or if the family weren't in a position to be recruited. So as we discussed then previously, I was interested in the timing and what time and what dose should be given. So in this study, in the HEAL trial, dose of 1,000 units per kilo were given over a 5-day period, and the first dose was given before 26 hours. And that was made on the decision as 1,000 units was well tolerated, and it fell within this range, 5 to 2,500, where it was known to reach a maximal concentration past the blood-brain barrier and be neuroprotective. And as we discussed before, these were the outcomes, which were quite clear. And the secondary outcomes were just leading on from that, was differences in the Bailey score and epilepsy, and the parents were also followed up by phone interview a 6-month period for child behavioral checklist scoring, and also they had an MRI brain at day 5, between day 5 and 6. So they sample size was calculated at 500, which is a relatively large sample size, and that was calculated. It was thought to would achieve power with a 10% loss. And interim analysis was performed at a 6-monthly period to find any significant adverse outcomes, but the trial was completed.
Sorry, those weren't interim analyses. Those were meeting with the DSMB. That's a very different thing.
Oh, sorry. Okay.
Yeah.
And then in terms of randomization, the it was centrally randomized, and each unit was stratified for severity and location, and both clinicians and assessors were blinded to allocation. Only the pharmacist was aware of allocation. And over 2,300 infants were assessed for eligibility. 501 went under randomization, and there was really an excellent follow-up rate of greater than 90%, despite this occurring during COVID. And that's why some of the assessments were done not at the 24-month period, but at the 36-month period because of the pandemic. Just reviewing the initial baseline characteristics of both groups, I was really quite similar between both groups in terms of the characteristics. And similarly, in terms of the delivery or place of birth, it was similar characteristics between both the erythropoietin group and the placebo group. So moving then to the outcomes in terms of better neurodevelopmental impairment at 26 to 30 months, there was no significant difference between the two groups. And similarly, just breaking down then the Bailey score at 36 months, cerebral palsy or the GMFC level was similar between the two groups. All initial outcomes that were set out were reported in the final and published in the final paper. So, as discussed previously, there was no difference between debtor neurodevelopmental impairment in the two groups. In terms of secondary outcomes, all were reported, and the only, interestingly, the erythropoietin scored higher for externalizing problems in the follow-up trial behavioral checklist, and I'm not quite sure why the erythropoietin group scored higher, but it's something to be looked into further and something of interest. MRI findings were similarly same between two groups, and the pattern of brain injury was quite similar. So moving into the adverse effects, as one of the main aims of the studies was to see if erythropoietin was safe. So in terms of serious adverse events per child, the erythropoietin group had a higher number of events per child. So looking then at the actual events, I noticed that convulsions or seizures weren't included in the serious adverse events, and I was actually interested to see was that because of it sort of being a known part of the HIE illness, or as when I looked further into the adverse events, there was more in the placebo group that had convulsions in comparison to the erythropoietin.
So, Dr. Joel, can you guide us through how the adverse events were selected, and do we think, looking retrospectively, we can revise this because systemic hypertension may not be as adverse as death maybe could have changed the profile of EPO being more risky? Dr. Julia muted.
Sorry. The way we chose the serious adverse events were based on EPO-related adverse events that have been documented in adults, and those included hypertension and thrombosis and polycythemia. The FDA, even though in neonatology polycythemia is not a thing that you have to worry about, they wanted to make sure that we included that in our SAEs. And then the other ones were things that were more related to HIE, so disseminated intravascular coagulation, pulmonary hypertension, and so on. So that's how we came up with the list. We, of course, also looked at all of the other adverse events, so comorbidities of HIE. And one thing to note about this is that we included serious adverse events from birth, not just from when the babies were enrolled. And I think that's important because there's certain, there's timings of these adverse events. So for example, DIC and systemic hypertension, pulmonary hypertension occur early, and some of these other ones occur later. So timing's important.
Yeah. And I think David had a question, any specific reason convulsions or seizures would, convulsion specifically was not included as an adverse event?
It was, the data on seizures was collected. We just didn't consider it a serious adverse event.
Okay.
And there was no difference in seizures between the groups.
Yep.
Yeah.
I mean, given how high the rate of seizures is,
Exactly.
you'd be
Yep.
pretty. I mean, you'd go insane reporting them. I had for the original hypothermia trials, I had a long discussion with the FDA about whether we should include death. And I said, look, if you make me include death, fine, we'll do it, but you'll get a report every week. Eventually, they took the point. They didn't want quite that number of event reports.
Interesting.
And it's correct. That's just a 30% rate, and it's going to be higher. The rate of seizures is going to be much higher again.
Yep. Sure.
Great. And this brings us nicely then to learning points from this study. So EPO is synergistic with hypothermia, but whether the protective of hypothermia effects have reached their maximum at this stage, and the EPO.
Yeah, I think David, we can break here for further discussion. So Dr.
Yeah.
Chait, starting you, looking back at the trial, would you have changed anything for this trial, such as timing of the EPO or the dosing of the EPO?
You're asking me?
Yeah.
Yeah. So yes, you can always say, well, maybe it should have been a constant IV infusion, or maybe it should have been 500 units every other day. Or, I mean, there's all kinds of maybes and what ifs that you can think of. But we went with our best data based on the animal work that we had done, basically. So we had identified a dose that was neurotherapeutic in rats. We did pharmacokinetics. We did phase 1 pharmacokinetic trials in humans to make sure that the serum levels that we got were comparable to serum levels that were neuroprotective in the animals. And so that's the dose that we went with. In the phase 2 trial, we had 5 doses as well. The timing was a little bit different, and we moved the 4th dose so that it would be obtained before the MRI, because the finding in the phase 2 trial was that the MRIs were improved. And so we thought, well, we'll just make sure that they get 1 more dose before the MRIs, thinking that that might make the differences even more marked. But I think, we went with the information that we had, and we don't have any more information now that I would say, oh gosh, we should have, done something else. I think, Alistair, you've done some different work in your sheep looking at different timings of
Yes.
EPO.
Yes.
And you might talk about that.
So in preterm fetal sheep, EPO given after asphyxia is protective if you give it early. It's not protective if you start the infusion late. And in fact, in one study where we gave bolus infusion starting at 6 hours, we actually found worse outcomes. Now, that was worse outcomes at day 7. Personally, I suspect that what we were doing is accelerating the evolution of necrosis rather than causing it. But it certainly wasn't better at 6 hours. So my one question here is EPO was given in the first day. Was it the first 26 hours? Something like that. Do you have actual times? What was the average time that it was given? Or
It was around 16. It was around 16 hours. I think the average time of enrolling into the study was around 14 hours, and then the EPO was given about 2 hours later. I could be off by 2 hours. It could be the average time of enrollment was 16 hours and the
Right.
dose was given at 18, but it was around there.
Yeah, so that's certainly late compared with the preclinical studies. As I say, we have yet to find any benefit from EPO given from 6 hours onwards in sheep, in that kind of acute sentinel event type of model. I mean, I can think of at least three reasons why the combination might not work, and that's one of them. But our study, we gave EPO and hypothermia starting at 3 hours, and we didn't find an effect of the combination. So I don't think timing was the critical issue. Some of it will be overlap of the mechanism of action, that both of them work through suppression of apoptosis and suppression of microgliosis. They can both do it very consistently. So it may well be that hypothermia is already at its optimum for suppressing those pathways. But also potentially hypothermia acts in a negative way. It's reducing intracellular effects, whereas EPO is acting by activating intracellular effects. I do wonder whether there's an adverse effect of hypothermia to actually suppress the intracellular events triggered by EPO, if you see what I mean. So there could be that could also be why the combination has not had reliable benefits. In Nikki's study, where she found some apparently small, but to be fair, very small additive effects, she was giving hypothermia for a much shorter period than the EPO. So the EPO, so it was unopposed EPO for a significant tranche of time. So
I think one thing I really need to just bring to the fore is there was many papers showing that EPO is anti-inflammatory and anti-apoptotic. And
yes.
when we looked at this in both the peanut trial and in the HEAL babies, that was not the case. So in human babies, EPO does not affect inflammatory cytokines whatsoever. And so I think the mechanisms of action are in rats and mice just can't be translated to humans. And so bullet point number 3, I think, is really critical. And we can't rely on rodent models of brain injury and think that they're going to translate across to humans without using larger animal models with gyrified brains.
I can only endorse this. Speak as somebody who works on human sheep.
Yeah, I mean, I think that's really a take-home message.
Yeah.
You know, rats can be used for screening, but they shouldn't be used in exclusion.
Yeah, David, you want to move ahead with further learning points in your slides?
Yeah, I think it shows we've discussed those, but the other important point is it shows the importance of large phase 3 randomized trials and gathering data from multiple smaller phase 2 trials, like have been done previously, can be quite misleading. It would be interesting. I'm not sure if this was in a lower middle income country where hypothermia wasn't available, or in a group that hypothermia wasn't available, could EPO be of use. And I think what we are moving more towards now is understanding that the group that we're looking at, the HI group, are quite a homogeneous group, and it's a heterogeneous disease process, with different types of HIE, with severity, the types of acuity, and also awaiting results from the trial, which will look at the epigenetics of HIE and how the disease process works. I think it is interesting to look at potentially multiple agents working at different areas, targeting not only the grey matter but white matter, moving forward to see if multiple agents will help with our HIE. And I did a small search of current studies that are going on, and we can see there's an array of agents that are being looked at in no particular order. They show that the world group is really looking to see if there's anything that can help with HIE. It was interesting that currently the Erythropoietin is being given, which has the same mechanism of action as EPO, the dantrol in the US, which may be able to be given a easier dosing. And similarly, of interest, the new sort of kids on the block would be stem cells, which are again in early phase 2 trials, and maybe come to the forefront in our treatment of HIE.
So I think it was a great trial, because I think the meta-analysis was showing that it may be beneficial to use APO with hypothermia, but this trial clearly shows that may not be that helpful. And I think the PEEN trial also is running in Australia. Dr. Gunn, do you have any update on how that trial is going, and will that help us further inform our practice?
I think Atul can speak to that better than I am. I believe it's finished recruiting, but doesn't yet have data to be analysed.
I think they recruited 300 patients, and they're just doing the follow-up now.
So as going back, if we have to design a new trial based on this data, what should we focus on? Should we skip the hypothermia part of it and just focus on giving erythropoietin or even darbepoetin in those in places where cooling is not really available, such as low middle income countries? Or how, because there is some evidence from preclinical data, animal models, it's useful for it. So do we think we can optimize further erythropoietin as a treatment option for HIE?
I think Sudin is doing a study
Correct.
with just EPO for HIE in low and middle income countries. So we should have some data in the next few years about that.
Yeah, that's my understanding too. The one thing I would say is what the preclinical data say to me is, if you're going to use EPO, it has to be as early as possible. So a long and I think fruitless conversation with Susan about the timing of EPO treatment. Was it possible to get around some the intrinsic delays with outborn babies if you don't treat them until they arrive at your tertiary hospital? I mean, I think it is, but the concern of all of the academics involved in that trial was that if they did that, they would immediately be jumped on by high and mighty people in the developed world, saying, how can you possibly do this? How can you possibly give prophylactic treatment or at a peripheral hospital in a baby when you haven't yet had full informed consent. I'm sure they're absolutely right. That's exactly what would happen. So that's a pragmatic problem. But the preclinical evidence all supports early treatment, not late treatment.
So Dr. Gunn, do you define early treatment as less than 6 hours or even shorter than that?
Even shorter than that. I would have said actually ideally within the first 3 hours, and 6 hours as an absolute maximum.
Okay.
Be targeting really, but I think the same is true of hypothermia. That ideally we should be treating with hypothermia within the first 3 hours of life, and there's some cohort-based evidence to support that in humans.
Yeah. So
I think the albino trial is a really great example of a trial looking at an intervention in the first hour of life, but they have had a very difficult time recruiting. So they have used the opt-out method. So parents get the request for consent after the fact, and they can either enroll or not enroll. But I mean, yeah, it's really difficult to do a randomized trial where you have to get the babies in less than 24 hours. It's very difficult.
Yes.
Yeah. Seems
And it's not just neuroprotection trials. I mean, if you remember the original trial of surfactant, I think they were what was it, 36 hours to the first dose, and they were just really lucky they got an effect.
Yes, exactly.
For it. So I'm gonna take some questions from the audience. The question is, do we know what is the timing of EPO in the PEEN trial? I don't know if Dr. Malhotra may know a better answer about this.
I'm pretty sure it's the same timing. So it's over the course of 7 days and within 24 hours or 26 hours or in the first day anyway. And the follow-up is up to 24 months with and they just had a smaller group of 300 as their target.
Okay, so very similar to this trial as such. Another question I had, Dr. Jewell, was about the adverse effects. So we've seen increased adverse effects with EPO in this trial. Do you think it's still safe to use this drug in future trials or for it, or if we should switch to a mode like a Erythropoietin or something else? Given the
We
safety
did a deeper dive to look at the effects, the safety effects, and so it's published. Actually, I think it was in JPEDS. So we looked at the SAEs that occurred prior to enrolling and giving EPO versus after enrolling and randomizing, and most of the effect went away, but there was still an increase in thrombotic events. They were rare, so there were 6 in the EPO treated group and 1 in the placebo group, but it was statistically significant. Having said that, there are thousands of babies that have been treated with EPO for the hematopoietic effect of EPO, and generally speaking, it's been found to be safe. So I don't know whether it's the combination of having HIE and EPO, but that is the one thing that we did see that was significant. Again, very small numbers, though.
Okay. Yes, Dr. Ginn, do you have any comment on the safety of EPO?
I mean, I admit that I don't understand how you can get thrombotic effects in the context of babies who are having multiple blood samples whose hematocrits are actually less than normal. So I'm guessing it's some interaction with dissemination intravascular coagulation. That this is indeed, it's not an independent effect. It's a combination effect with DIC after severe asphyxia. That's my best guess. By itself, I can't see how this can possibly happen.
Yeah. You know, one thing we didn't look at was the interaction between EPO and platelet transfusions. And that is something that we probably should have done in that safety analysis. But
Sure, and it also may be the combination with hypothermia. That hypothermia is reducing peripheral blood flow, and might therefore it had an indirect effect again with EPO to promote thrombosis. So if I have to guess, my guess is that used in moderate HI, actually the safety outcomes will probably be even better than at HEAL. But that is totally me extrapolating from the literature.
Yeah, that's one thing that combining our data with the pain trial will be very helpful, because that'll give us 800 babies with basically the exact same protocol. So there is one difference. The dose is the same, but the pain trial was based off the phase 2 trial that we had. So the 4th dose of EPO is 1 day later, but basically it's the same protocol.
So yeah, I think the results of those trials will clearly give us more whether should we use EPO with hypothermia or not. And Dr. Gunn has suggested maybe giving earlier without hypothermia would be a better option, but we're going to face a lot of pragmatic challenges to get that data as such for it. So I think we're almost at time. So I think on a personal, I think it's a great trial to inform us as a translation researcher myself. What we do in animal data sometimes may just not translate in human physiology as such. So Dr. Jewell, do you want to give any final closing comments to a future trialist here? The lessons learned from the trial and how they should work towards designing future trials?
Yeah. Well, I would say that this really highlights the importance of phase 3 trials, and you can't just combine a bunch of phase 1, phase 2 trials and think you have the answer. It really does take a phase 3 trial. And one thing I'm very proud of is that this was a very well done study. And so I think we really can trust the data that we, the results that we came up with. The other take-home message for me was what I've already said about rats and mice. And again, I think that spine is a screening animal model, but I really feel strongly that more work has to be done in gyrified larger animal models prior to going to large clinical trials.
Yeah.
So we've started using the ferret in our lab, which is, I think, the smallest animal with a gyrified brain, and we can look at long-term behavior in those animals. So they're a great model. But I think we need to use all the models that we have: Alistair's sheep and Nikki's piglets, and so on. So I think it just highlights the importance of doing a good job in the preclinical work, making sure the animal numbers are large enough, right? And that the work is repeatable, right? So like if you look at some of the old literature, like 8 animals per group, and they don't separate them by sex, like that doesn't cut it. That's not enough data. So I think doing a good job on preclinical studies is really essential to guide us in the work that we carry forward into humans.
Yeah, and I'm glad Dr. Gunn is leading that efforts. Dr. Gunn, you have any final closing comments for trainees?
Yes, I think we've learned, even though HEAL was negative, and I think just replicates the sheep data, nevertheless, we've learned the randomized controlled trials over time had taught us a huge amount about HIE, things that we didn't know. I've been doing this for a long time. I can only say we have learned an enormous amount about the basic biology, about the treatment of HI, and we've learned it all from trials. That's the only way we get large amounts of well collected systematic data that tell us what's important and what's not so important. And we've already learned a huge amount from the secondary analyses of HEAL, and I know there's more to come. So I think even if they're not successful, I still wish to see lots more trials.
Correct. Yeah, and all of our trainees are grateful for you for leading this trial and to learn from you guys. So I think we'd like to close this session. Just for our audience, we'll be taking a break for the next few months before we resume our further sessions. We will continue to invite international fellows and trainees. So if anyone knows who would like to present, feel free to shoot me an email at jane@uab.edu. And we, Dr. Gunn and Dr. Joel, many thanks for coming, for taking time with your busy schedule. An excellent job, David. It was a great presentation, and sorry to wake you up so early to
No,
give this
that's okay.
presentation for it. Thank you very much. Thank you all for coming.
Thank you so much. Bye now.
Thank you.
Thanks.